Hello and good evening, everyone. So, how are you all doing? So, I hope all of you are fine and doing well. So, welcome to another live session on Idento. So, today's live session is mainly for the exam going third year students and also the NEET MDS aspirants. Okay, so today we are mainly going to discuss about a major topic in oral pathology, which is the odontogenic cyst. Okay, so for the third years, I was going through the previous year university examination papers and uh, like lots of essay questions and short notes were frequently asked from odontogenic cyst. Okay, so while I was going through the previous year papers, like repeatedly, lots of odontogenic cyst questions were asked in the essay section. And almost these questions have the similar pattern. Like first, it will be like definition of the cyst, define cyst, then classify the odontogenic cyst, then add a detailed note on a particular cyst. Okay, so it can be like the clinical features, radiographic features, and the histological features of a particular cyst. Okay, so mostly like the frequently asked ones are definitely the dentigerous cyst and the odontogenic keratocyst. Okay, so these were the very common questions that I came through when I was searching the university papers in the essay section. Okay, definition of cyst, classification of cyst, then a particular detailed note about a particular cyst. Okay, usually they were asking about dentigerous cyst and the odontogenic keratocyst. Okay, so if you look at the short note section or the brief note section, again, sometimes a particular feature of the odontogenic cyst is asked, like the histological features of radicular cyst or the radiographical features of the dentigerous cyst. Okay, then about the Rushton bodies or the Gauss cell or the cholesterol cleft or the Gorlin-Gall syndrome, calcifying odontogenic cyst and eruption cyst, all these were asked as short essays and short notes also. Okay, so in this session, we'll be dealing with all the questions that were related to odontogenic cyst section. Okay, so first we will go to the essay question. So in the essay question, like I had mentioned in the previous salivary gland session also, always write contents for the essay question in the contents, like give a brief about what you are going to include in that essay. Okay, just write as a point wise, like the definition. If they ask about the definition, then write in the content section, include the first point as definition, then the classification. Then if they had asked about OKC, then about OKC, in related to OKC, just give an introduction first, then the clinical, radiographical, and histological features, treatment, and they may particularly ask you to add a note on the recurrence of OKC. Okay, because since OKC is the most recurring odontogenic cyst, they may ask you to add a note on the recurrence of the odontogenic cyst also. Okay, so let's see about first the definition of cyst. Okay, so what is a cyst? Okay, so this definition is uh, uh, the classic definition of the cyst. Okay, so this is the definition that you should write. A cyst is a pathological cavity. Okay, that is having fluid, semi-fluid, or gaseous contents that are not created by the accumulation of the pus. Okay, it is not created by the accumulation of the pus. If it is created by the accumulation of pus, then it will be called as an abscess. Okay, so this is not created by the accumulation of pus, but it has like fluid, semi-fluid, or some kind of gaseous contents inside it. Okay, and most cysts, but not all of them, are lined by epithelium. Okay, so if a cystic cavity is lined by epithelium, then it is called as a true cyst. Okay, if it is not lined by an epithelium, then it is called as a pseudocyst. Okay, so most of the odontogenic cysts that we are going to discuss today, they are all true cysts. Okay, and one more thing that you have to like be very careful while writing the definition is that always write the person's name who gave the definition. Okay, so if you can include the year also, well and good. Okay, so Kramer was the one who gave this definition in the year 1974. Okay, so always mention the person who gave the definition and the year also. Okay, so while writing any definition, okay, any definition in any topic, in any subject, please make sure that you write the person who gave the definition and the year. Please make sure that you mention the year also. Okay, so it was Kramer in 1974 who gave this definition. Now let's have a look at the parts of the cyst. Okay, so the parts of the cyst, mainly a cyst has three parts. Okay, so the central part or the central hollow part or the central part of the cyst, it is called as the lumen. Okay, so this white part, that is called as the lumen. Here the white part, that is called as the lumen. Okay, the central part which is enclosed, the central enclosed part of the cyst, that is called as the lumen. Now this lumen will be surrounded by an epithelium. Okay, so this lumen will be surrounded by a lining epithelium like this. This dark colored structure you see here, yes, that is the lining epithelium that is covering the lumen. So that constitutes the epithelial lining of the cyst. Now, like in our body, like any epithelium will be usually supported by an underlying connective tissue. Okay, so underneath the epithelium, you will have a connective tissue wall also for the cyst. Okay, so these are the three parts of the cyst. You will have a lumen, you will have an epithelial lining, and you will have a connective tissue wall. Okay, so these three parts are important because while writing the histological features, please make sure that you write regarding these three parts clearly. Okay, that's really important because then only you will not miss out any features also. Okay, so some cysts have some kind of features in the lumen. Some cysts have like particular like features in the epithelial lining, and in the connective tissue, some cysts have like particular features also. So please make sure that while writing, for your clarity, for more clarity and for your ease of writing also, please make sure that you mention these three parts clearly. Okay, so for easily understanding the parts of the cyst, these three parts of the cyst can be compared to that of the parts of a coconut. Okay, so just for easily understanding, that's all, for ease of understanding for you. Okay, so the inside part of the coconut, that is more like the lumen of the cyst. Okay, and the white part of the coconut, which is called as the coconut meat, that can be considered as the lining, as the epithelial lining of the cyst. And the outermost part, okay, that is the brown part of the coconut, that it can be considered as the connective tissue wall, that the hard part or the rigid part of the coconut, the outermost brown part, yes, that can be considered as the connective tissue wall of the cyst. Okay, so the parts of the cyst are similar, somewhat similar to that of parts of the coconut. Okay, this is for easily understanding this stuff. Okay, so coming to the classification of the cyst. Okay, so cyst of the jaws can be classified broadly into two types. We have the odontogenic cyst and we have the non-odontogenic cyst. Okay, so odontogenic cyst means the cysts that are formed from the tooth forming apparatus. Okay, so tooth forming apparatus means mainly the dental lamina is contributing and all the dental sac is contributing, and all these structures that we had already studied in the first year, they are the ones who contribute to the tooth formation. Okay, so if the cyst is forming from any of these tooth forming apparatus, then that cyst is included under the odontogenic cyst category. Okay, so if it is not formed from the odontogenic apparatus, then it is included under the non-odontogenic category. Okay, so this is the broad classification of the cyst of the jaws. Cyst of the jaws can be broadly classified into odontogenic and non-odontogenic. Okay, so here we are mainly focusing on only the odontogenic cyst. So let's see how this odontogenic cyst is classified. Okay, we are mainly focusing only on the WHO classification. Okay, and WHO has updated its classification like frequently. Okay, there was a classification in 92, then 2005, then 2017, and in latest classification of WHO was in the year 2022. Okay, so here I am mentioning the latest WHO classification of odontogenic cyst. It may not be there in some of your textbooks, but please remember that this is the updated 2022 classification of WHO of the odontogenic cyst category. Okay, so it is not like classified into developmental, inflammatory, and other cysts, but we can like differentiate the odontogenic cyst into put this odontogenic cyst in these three categories. Okay, there are developmental cyst, then there is inflammatory cyst, and there is the other cyst also. Okay, so the developmental odontogenic cyst includes dentigerous cyst, OKC, gingival cyst, OOC, and the lateral periodontal cyst, calcifying odontogenic cyst, glandular odontogenic cyst, and the surgical ciliated cyst. Okay, so these are the 8 cysts that are present in the developmental odontogenic cyst category, and you can remember these cysts with the help of the mnemonic. Dentists often go on long clinical grand sessions. Okay, dentigerous, OKC, gingival cyst, OOC, lateral periodontal cyst, and calcifying odontogenic cyst, glandular odontogenic cyst, and the surgical ciliated cyst. Okay, so the surgical ciliated cyst is newly included under this odontogenic category. The cyst has been there for a long time, and it has been mentioned in the literature also, but it has been newly included under this odontogenic cyst category. Okay, developmental odontogenic cyst category. This cyst has been newly included. Surgical ciliated cyst. Okay, most of these cysts are seen in the maxillary region, and after like some kind of like orthodontic surgeries and all, these cysts were noticed in some patients. Okay, so they had included this cyst under the developmental cyst. Okay, so this is a new entity, surgical ciliated cyst. Okay, then we have the inflammatory cyst. Inflammatory cysts include radicular cyst and inflammatory collateral cyst. Okay, so these are the only 2 inflammatory cysts that are included under this new classification. Then in the other cyst category, we have the nasopalatine duct cyst also. So we'll be dealing with one by one, like one cyst at a time in the following slides. Okay, so first one is the dentigerous cyst. Okay, so dentigerous cyst is also called as follicular cyst. Okay, and it is the most common developmental odontogenic cyst. Remember, it is the most common developmental odontogenic cyst. Okay, it is not the most common odontogenic cyst. It is just the most common developmental odontogenic cyst. Okay, so the it accounts for nearly like 20% of all the cases will be usually dentigerous cyst only. Now, how this dentigerous cyst is getting formed is that if this is an impacted tooth, this impacted tooth will be covered by a flattened layer of cells. Okay, that is called as the reduced enamel epithelium. Okay, so in between this crown of this impacted teeth will be usually covered with this reduced enamel epithelium. Okay, now because of some alteration in the hemodynamic mechanism, what happens is that there will be fluid accumulation in between the crown and this reduced enamel epithelium. Okay, so lots of fluid starts getting accumulated between the crown of the impacted teeth and the reduced enamel epithelium. Okay, so that will result in the formation of a cyst like this shown here. Okay, so that will result in the formation of a cystic structure like this. Okay, so that kind of cyst is called as the dentigerous cyst or the follicular cyst. Okay, why follicle? Because it results in the separation of the follicle from the crown of the unerupted tooth. Okay, so that's why it's called as a follicular tooth. Mostly, okay, most of the cases of dentigerous cyst are associated with an unerupted tooth only, mainly seen in the mandibular third molar area. Okay, then the next common site is the maxillary canine region, then the maxillary third molars, and the mandibular second premolars. Okay, so these are the common sites where you can see the dentigerous cyst, and most commonly seen in the young patients, like those between the age group of 10 to 30 years. Males are most commonly affected, and white people are most commonly affected than the black race. And small cyst will be usually painless, and it will not produce any swelling also. But if the cyst is large or if it is infected, then it can cause pain and swelling in that area. Okay, and it can produce facial asymmetry like this. Okay, facial asymmetry, pain, swelling are all common features of dentigerous cyst. And multiple dentigerous cysts are usually seen in the Maroto-Lamy syndrome. Okay, so multiple dentigerous cysts are usually seen in the Maroto-Lamy syndrome. Okay, so this is the gross picture of the dentigerous cyst. As you can see, the cyst is getting attached to the cemento-enamel junction of the tooth. Okay, it's like the crown portion of the tooth is completely enclosed inside the cyst. Okay, so this will create like a neck-to-neck attachment. Okay, so this neck-to-neck attachment is a characteristic feature of dentigerous cyst. So if you look at the radiographic features also, you'll be able to see unilocular, well-defined unilocular radiolucent area like this. Okay, well-defined unilocular radiolucent area like this with well-defined borders and corticated borders. Okay, so what do you mean by corticated borders? Okay, so corticated borders means like surrounding the radiolucent area, there will be a very thin white line present. Okay, so this thin white line that represents the corticated border. Corticated border means it mainly shows a slow growing lesion. Okay, it mainly shows a slow growing lesion. That is, the body's defense system, it got enough time to react against this lesion. Okay, so that's why this corticated borders are seen. Okay, so this is the clinical or the radiographical picture of this dentigerous cyst, and this dentigerous cyst can be radiographically based upon the location of the cyst and based upon the relationship of the cyst to the crown region. It can be of three types. We have the central type like this, then we have the lateral type like this, and we have the circumferential type like this. Okay, so one thing that you can notice in these three types are that the attachment is always at the cemento-enamel junction. For lateral also, it is extending towards one side, but see the attachment here. The attachment is always at the cemento-enamel junction. Okay, it is not changing. Okay, so that is called as this neck-to-neck attachment. Then here also circumferential means it will be like completely enclosing the tooth, but still look at the attachment of the cyst. It will be always at the cemento-enamel junction. Okay, so these are the three types of dentigerous cyst. You have the central type where the whole cyst encloses the crown of the tooth, and you have the lateral type, which is most commonly seen in case of mesioangular impacted cases. Okay, so the cyst will be growing mainly towards one side, and the circumferential type, it seems like the whole cyst encloses the whole tooth, but the attachment is always at the cemento-enamel junction. Okay, and then displacement of the impacted tooth can be seen. Sometimes this, from the pressure of the cyst, the tooth can get displaced towards the ramus area, and the root resorption is very common in dentigerous cyst. If you look at the adjacent tooth structures, you can see the root resorption very clearly. And usually, if a radiolucent area is only like 3 to 4 millimeter or greater in size, then only we call it as dentigerous cyst. Okay, if it is less than 3 or less than 2 millimeter, then that can be considered as a hyperplastic dental follicle also. Okay, so that is the differential diagnosis for small dentigerous cyst. So usually if the size is like greater than 3 to 4 millimeter only, we will consider it as dentigerous cyst. Okay, then next coming to the histopathology of dentigerous cyst, like I had already mentioned, the parts of the cyst, you have to describe about the lumen, you have to describe the epithelial lining, and you have to describe the connective tissue wall. Okay, so the lumen will be uncharacteristics. Okay, not much characteristics will be seen there in the lumen. So this is the pictorial representation of the dentigerous cyst, which you can draw in your answer papers. Okay, so the lumen, not much characteristics are seen. Then the lining. Okay, the lining epithelium of dentigerous cyst resembles that of the reduced enamel epithelium. That is usually 2 to 4 cells thickness, non-keratinized stratified squamous epithelium is seen. Okay, so 2 to 4 cell thickness of non-keratinized stratified squamous epithelium is seen, and there will be no retiridges. Okay, for a non-inflamed dentigerous cyst, there will be no retiridges. The epithelium connective tissue interface, okay, that will be usually flat only. Okay, and if you look at the connective tissue, in the connective tissue, you will be able to see like loosely arranged fibrous tissue will be there. If it is non-inflamed, there will be no inflammatory cells. Also, no inflammatory cells will be seen. And in the connective tissue, sometimes you can see odontogenic epithelial islands like this. Okay, small islands of odontogenic epithelial islands or the Sylvester of Seren. Yes, you can see such islands in the connective tissue. Okay, and sometimes you can see the cholesterol clefts also. Okay, so I'll be discussing in detail about cholesterol clefts in the coming slides. So these are the main things that you see in the dentigerous cyst. The lining, similar to epithelium, reduced enamel epithelium, 2 to 4 cells thickness, non-keratinized stratified squamous epithelium, flat epithelial connective tissue interface. Inflammation will be usually less. Odontogenic epithelial islands can be seen in the connective tissue, and fibrous vascular tissue will be seen, and cholesterol clefts may also be seen in the dentigerous cyst. Okay. So the coming to the treatment of the dentigerous cyst, usually we enucleate the cyst. Almost for all the cysts, usually the treatment is enucleation with the removal of the unerupted teeth. And for large dentigerous cyst, we can do marsupialization also. Okay, so marsupialization means we will try to decompress the cyst. Okay, so we'll try to decompress the cyst so that the size of the cyst gets reduced. Okay, so once the size of the cyst gets reduced, it will be easily enucleated. Okay, so that's what we do for large dentigerous cyst, and the prognosis, it has an excellent prognosis, and the recurrence is not that common. Okay, so but for long-standing dentigerous cyst, some complications can arise, like ameloblastoma can arise from the lining of the dentigerous cyst, or sometimes squamous cell carcinoma can arise from the lining of the dentigerous cyst, or sometimes intraosseous mucoepidermoid carcinoma can also arise from the lining of the dentigerous cyst. Okay, so intraosseous mucoepidermoid carcinoma is a salivary gland tumor. Okay, so how is a salivary gland tumor arising from an odontogenic cyst? Okay, that's because sometimes this lining of the dentigerous cyst, it will show mucus cells like this. Okay, so it will show mucus cells like this. Only such cyst may in future progress to mucoepidermoid carcinoma. Okay, so these are the three major complications of long-standing dentigerous cyst. Now, one cyst that is like very much similar to this dentigerous cyst is the eruption cyst. Okay, so this eruption cyst is considered as a soft tissue analog of dentigerous cyst. Dentigerous cyst is occurring inside the bone, whereas this eruption cyst is occurring in the soft tissues. Okay, so what is happening is here also there is like fluid accumulation between the crown of the unerupted tooth and the overlying gingival tissue. Okay, so just like that, here also the fluid accumulation is happening. But here, the fluid is getting accumulated between the crown of the unerupted tooth and the overlying gingival tissue. Okay. Now, sometimes what can happen is that uh, because of the trauma from the underlying teeth, what can happen is that blood also can get accumulated inside with this cystic fluid. Okay, so blood also can accumulate inside this cystic fluid. Okay, so that will result in a blue to purple brown color like this. Okay, so it will result in a blue to purple brown color like this, and this is called as eruption hematoma. Okay, so eruption cyst occurs due to accumulation of fluid between the crown of the unerupted tooth and the overlying gingival tissue. And if because of some trauma or because of some irritation, if blood is also getting mixed with that of the cystic fluid, then it is called as eruption hematoma. Okay, so most commonly seen in the children. Okay, below 10 years. Okay, there the when the tooth is in the eruption stage, you can see this rarely this eruption cyst. Okay, most commonly seen in the decidus mandibular central incisor region, then the first permanent molar region, and also in the decidus maxillary region. You can see this eruption cyst. Okay, so it will appear as a soft bluish translucent swelling like this in the gingiva. Okay, so then you can suspect the eruption cyst also. Okay, so if you look at the histopathology of this eruption cyst, usually like after biopsy, it is very difficult to get the whole cyst, whole eruption cyst. What we can usually get is the just the roof of the cyst. Okay, so when you look that roof of the cyst under the microscope, you'll be able to see something like this. Okay, the overlying oral epithelium will be there, or the overlying gingival epithelium will be there. That will be keratinized stratified squamous epithelium. And then the connective tissue will be there, which will have like lots of inflammatory cells. And then underneath, you will have the roof of the cyst. Okay, very thin roof of the cyst can be seen, which is made up of non-keratinized stratified squamous epithelium. Okay, so very thin roof like this will be seen, which is the roof of the eruption cyst. Okay, so the treatment is usually not required. So if the usually what happens is that the eruption cyst will rupture on its own and the tooth will erupt into the oral cavity. But sometimes if the cyst does not rupture, then you can do a simple excision and allow for the tooth to erupt into the oral cavity. Okay, so this treatment of eruption cyst was a question that was asked in the recent NEET MDS. Okay, so coming to the OKC, next cyst is the OKC or the odontogenic keratocyst. It is one of the most controversial odontogenic cysts. Earlier, in this WHO classification itself, they had included this odontogenic keratocyst under the tumor category. Then they again felt like it should not be under the tumor category, and it is now included under the cyst category itself. Okay, so it was earlier called keratocystic odontogenic tumor, but it is not included under the tumor category anymore. So this term is also discarded. Okay, so this keratocystic odontogenic tumor, that term is not used nowadays. Okay, now it is just odontogenic keratocyst alone. Okay, so this odontogenic keratocyst, it usually arises from the cell rust of serrae. Okay, the the dental lamina remnants, it arises from the cell rust of serrae. And in some odontogenic keratocyst, it shows PTCH1 gene mutation. Okay, which is also called as the patch gene mutation. Okay, not all the keratocysts, but some of them, they show this PTCH1 gene mutation. Now, I'll tell you where you will see this PTCH1 gene mutation and all in the and which syndrome is associated with it. But just remember that this OKC is associated with some of the OKCs is associated with PTCH1 gene mutation also. Okay, so it is the second most common developmental odontogenic cyst after the dentigerous cyst. Most commonly seen in the 10 to 40-year age group, males are most commonly affected. And like the dentigerous cyst, it is also seen in the posterior body of the mandible and the ramus. Large cysts can definitely produce pain, swelling, and drainage like that. Okay. And one of the characteristic feature of this odontogenic cyst is its growth pattern. Okay. If you look at all the other odontogenic cysts, they grow in a buccolingual direction like this. Okay. So they grow in a buccolingual direction like this. Okay. But this OKC alone, it grows in an antero-posterior direction like this. Okay, it grows in a antero-posterior direction like this. Okay, so this is the major difference regarding the growth pattern of odontogenic keratocyst. Okay, so in case of like dentigerous cyst or calcifying odontogenic cyst or some other cyst, they grow in a buccolingual direction. Okay, so we can detect them very easily at an early stage itself. Okay, but OKC, since it mainly grows in the anterior-posterior direction, initially there will be no swelling seen in the patient. Okay, so once it reaches a considerable size only, you will be able to see a swelling. Okay, so by that time, most of the mandible may be involved. Okay, so that is one of the characteristic feature of OKC, and multiple OKCs are usually seen in a syndrome which is called as the nevoid basal cell carcinoma syndrome, or it is also called as the Gorlin syndrome. Okay, it is also called as the Gorlin syndrome. Now coming to radiographic features, it can show well-defined radiolucent area that may be unilocular like this, or it can be multilocular like this. Okay, the edges will be, or the margins will be usually smooth and corticated margins. Large lesions can be multilocular like this, and sometimes it can be associated with an unerupted tooth. And resorption of the root is comparatively less. Okay, you can see here. The root resorption is comparatively less when compared to the dentigerous cyst. Okay. Now the histopathological features. Okay, the histopathological features of OKC are characteristic of this cyst. Okay, you cannot confuse it under the microscope. Okay, mostly it will be like a textbook picture only. We'll be seeing in the patients also. So this is the only cyst which has a keratinized stratified squamous epithelium in the epithelial lining. Okay, so this is the only cyst which has a keratinized epithelium. So this keratin will be seen in the cystic lumen. Okay, so if this is the cystic lumen, the cystic lumen can contain keratin debris like this. Okay, and coming to talk about the epithelial lining, the epithelial lining will be usually um, parakeratinized stratified squamous epithelium. It will be usually like 6 to 8 cell thickness will be seen. And if you look at the topmost layer, okay, if you look at the topmost layer of this epithelial lining, it will be usually wavy or corrugated appearance is seen. Okay, look at the topmost layer of this OKC. Yes, it shows a wavy or corrugated appearance like this is seen. Okay, then next underneath those cells, we have the spinal cells, and underneath those spinal cells, we have the uh, basal cells. Okay, so there are like characteristic feature of basal cells are seen because these basal cells, they are like the amyloblast like cells. Okay, they appear like the picket fence appearance like this, or the tombstone appearance like this of the basal cells is very prominent in the odontogenic keratocyst. Okay, so and they have a very dark hyperchromatic nuclei is there, and this nuclei is present towards the, this nucleus is present away from the basement membrane. Okay, so these are the characteristic feature of the basal cells of OKC. Okay, so this is all about the epithelium. The surface will be usually wavy or corrugated in appearance like this. Underneath, you will have the spinal cells, and the basal cells are the characteristic feature to identify in OKC. They shows a picket fence appearance or tombstone appearance like this. The very dark hyperchromatic nuclei, and it will be placed away from the basement membrane. Okay, so while drawing the picture of this OKC, please make sure that you draw these features correctly. Okay. And next thing is that the epithelial connective tissue interface. Okay. Here also there will be no ruddy ridges. The epithelial connective tissue interface is usually flat. And since it's flat, because of the harsh treatment in the tissue processing, what happens is that sometimes the epithelium can get dislodged, can get separated away from the connective tissue. Okay, so it can create a gap like this in some areas of the OKC. Okay, so that's normal because since there are no ruddy ridges, the connection between the epithelium and the connective tissue is a little bit weak. So what can happen is that separation can be seen between the epithelium and the connective tissue. And since it's a developmental odontogenic cyst, the inflammation will be like very less in nature. Okay. So coming to the histopathology of OKC, please remember these 6 P's. Okay, so while writing the histopathological features of this OKCs, please make sure that you mention these 6 P's in your answer paper. Okay, so what are those 6 P's? First is the parakeratinized epithelium. Okay, the epithelium will be parakeratinized. Then next is the basal layer. Okay, so about the epithelium, there is only one point, only one P. Then the remaining of the things are about the basal layer characteristic. Okay, so the basal layer will be prominent. Like when you look at the microscope, you can like really see those basal layer. Okay, because that will be the very prominent layer that you can see in OKC. Okay, so prominent basal layer, then it will have palisading nuclei. Okay, so what do you mean by palisading nuclei in basal layer? Palisading nuclei means, suppose if you are taking this OKC histopathology, and if you are trying to draw a line by joining all the nuclei in the basal layer. Okay, you are trying to draw a line by joining all the nuclei in the basal layer, then that line will be parallel to the basement membrane. Okay, so that is called as the palisading arrangement of the nuclei in the basal layer. Okay, you draw a line connecting all the nucleus in the basal layer. That line will be parallel to the basement membrane. Okay, so that is called as the palisading arrangement of nuclei in basal layer. Then the nuclei will be polarized. Polarized means they will be placed away from the basement membrane. Okay, then you will have a hypochromatic nuclei or a pitch dark nuclei. You will have very like dark bluish color it will be. Okay, very dark bluish color nuclei you will be able to see. And then the appearance of this basal layer, it is called as the picket fence appearance. Okay, so these are the 6 P's of the OKCs. Please remember these 6 P's and make sure that you don't skip or you don't skip any of these P's while writing your answer. Okay. Now, next is the regarding the how is this OKC different from other odontogenic cyst? Okay, so what makes this OKC different from other cyst? Okay, so first one is its high recurrence rate. Okay, so the treatment for this OKC is usually enucleation along with the curettage also. Okay, and then we usually do the chemical cauterization also with the help of Carnoy's fluid. Okay, so that is for reducing this recurrence, but still in some cases, OKC seems to recur in those same sites again and again. Okay, so this high recurrence rate may be attributed to the presence of satellite cyst in the connective tissue. Okay, so if you look at the connective tissue of this OKC, you will be able to see like small cyst-like areas like this. Okay, so these are the satellite cyst or the daughter cyst. Okay, so these daughter cysts are responsible for the recurrence, for the increased high recurrence rate of the cyst. The next is the connective tissue wall. It has a very thin friable connective tissue wall. So most of the time what happens is that the surgeons may not be able to completely eliminate the connective tissue wall. So sometimes the remnants will always be there inside the site. That can also lead to the recurrence of this OKCs. Okay. Then next is the aggressiveness. Okay, it's a very highly aggressive cyst. and it just invades the underlying structures very easily also. Okay, so that's a very highly aggressive cyst is OKC. The next is the gene mutations. PTCH1 gene mutation is usually seen in OKC only. Then the next one is the aspirate. Okay, so we can do a procedure that is called as the fine needle aspiration cytology. Okay, so in fine needle aspiration cytology, what we do is that we can try to aspirate the liquid from the cystic region. So when we aspirate OKC, you will be able to see, get a cheesy white aspirate like this. So this cheesy white aspirate is a characteristic feature of OKC only. Okay, so because of the presence of keratin only, this cheesy white aspirate we are getting. Okay, so like I had already mentioned, there will be so much keratin in the lumen. Okay, so because of the presence of so much keratin, what happens is that the serum cannot like penetrate into the cystic lumen. Okay, so what happens is that the liquid in the lumen will have a protein content that will be less than 4 gram per dl. Okay, so if you look at the protein content of the liquid in all the odontogenic cysts, almost all the other odontogenic cysts will have a protein content that will be greater than 4 gram per dl. Okay, that they will have a higher protein content. But this OKC alone will have a lower protein content of 4 less than 4 gram per dl. Okay, so this is also as attributed to the presence of the keratin. Okay, since the keratin is like a very hard structure, the outside serum cannot penetrate easily inside the cystic lumen. So that can create a less protein content like this. Okay. Then next is the presence of satellite cyst, which we had already mentioned. Okay, so these are the features which like differentiates OKC from the other cyst. First is the genetic mutation, then FNAC aspiration aspirate. If you look at it, cheesy white aspirate you will get, and the protein content of this cystic fluid is also less. Then you have the satellite cyst, which are responsible for the high recurrence also, and the aggressiveness also of the cyst. Okay, so these are the features that differentiates OKC from the other cyst. Now, multiple OKCs are seen in a syndrome which is called as the nevoid basal cell carcinoma syndrome. Okay, so this nevoid basal cell carcinoma syndrome, it is also called as the Gorlin syndrome. It is an autosomal, it shows an autosomal dominant inheritance pattern. And in this syndrome only, we are seeing this mutation in the patch gene or the PTCH1 gene, which is there in the chromosome 9q22. Okay. So in this syndrome, you'll be able to see characteristic facial appearances like the frontal and temporoparietal bossing will be seen, mandibular prognathism will be seen, the cranial circumference will be usually increased, multiple basal cell carcinomas can be there, and multiple OKCs will also be there in the jaws. Ovarian cysts and fibromas are commonly seen. Skeletal abnormalities like bifid ribs and kyphoscoliosis and epidermal cyst of skin, palmar and plantar pits, these are all the common features of this Gorlin syndrome. Okay, so if you look at the OKCs that are present in this Gorlin syndrome, they will be usually associated with unerupted teeth. Okay, so it is usually confused with that of dentigerous teeth also, but actually they are OKCs in this syndromic patient. Okay, and if you look at the histopathological feature, you will be able to see more satellite cyst. Okay, more the satellite cyst, more the chance of recurrence also. Okay, so and odontogenic epithelial rust also you'll be able to see high in number. So for like diagnosing this nevoid basal cell carcinoma syndrome, they had given major criteria and minor criteria. So this major criteria include like 5 or more basal cell carcinomas or one before the age of 30 year itself, and multiple OKCs, this lamellar calcification of all cerebri, 2 or more palmar or plantar pits, first degree relative, and medulloblastoma are all included under this major criteria. And minor criteria include macrocephaly, increased cranial circumference, cleft palate or lip, frontal bossing, and all the facial features that we had already discussed. Then polydactyly, increased extra fingers in the hands. Okay. Then the rib or vertebral anomalies will be seen. ovarian or cardiac fibromas, ocular anomalies are all included under this minor criteria. Okay, so how will we diagnose a patient has a nevoid basal cell carcinoma or not? If the patient has two major criteria, okay, any two of these major criteria, then we can confirm that, okay, this patient has Gorlin syndrome. Or if the patient has only one major criteria and two minor criteria, then also we can confirm that, okay, this patient has Gorlin syndrome. Or if the patient satisfies only one major criteria like BCC or OKC or calcification of false cerebri only is there, but along with that, genetic confirmation is also made. That is, the mutation in PTCH gene is also confirmed. Then we can confirm that, okay, this patient is having Gorlin syndrome. Okay. The next one is the radicular cyst, which is also called as the periapical cyst or apical periodontal cyst. Okay. So if anyone asks you a question like which is the most common odontogenic cyst, then the answer is radicular cyst. Okay. Almost 60% of the cyst that we see in the jaws, if they are odontogenic, then it will be radicular cyst only. Okay, so it is the most common jaw cyst and it is also the most common inflammatory cyst also. Okay, so it is the main, it is an inflammatory cyst. So what is mainly happening is that because of some kind of trauma or because of some kind of caries, what is happening is that pulpal necrosis is happening, and then the infection is going into the apex of the root, and from there it is like invading the underlying bone also. So it is forming a cyst-like structure in the apex of the root, which will result in the formation of the radicular cyst. Okay, so mainly the origin of this radicular cyst is from the cell rust of molasses, which is the remnants of the Hertwig's epithelial root sheath. Okay, so this periapical cyst, it can be discussed or it can be differentiated into 4 types. Okay, we have first the periapical pocket cyst like this. Okay, so this is the periapical pocket cyst. As you can see, this cyst will always be connected with that of the root canal. Okay, so the cyst, the radicular cyst, which is connected with the root canal, that is called as the pocket cyst. Okay, if it is not connected with the root canal and it is seen as a complete, complete circle or a complete sphere, then it is called as a true cyst. Okay, so this is the pocket cyst, which will always have its connection with the root canal. And this is the true cyst, which is usually separated from that of the root canal. Okay, then you have the lateral radicular cyst. Lateral radicular means the cyst will be formed through one of the lateral canals of the root. Okay, so that will result in a lateral radicular cyst like this. Okay, it's very difficult to identify this lateral radicular cyst with the help of radiology because it can be confused with the lateral periodontal cyst also. Okay, so this one was like a difficult to identify. Then we have the residual cyst. Residual cyst means the non-vital tooth which formed the radicular cyst was already extracted, but still a radiolucent area will be seen in the jaws. Then that kind of cyst is called as the residual cyst. Okay, so these are the 4 types. We have the pocket cyst connected with the root canal, true cyst not connected with the root canal, lateral radicular cyst formed through the lateral canal, and residual cyst. The tooth is already extracted, but the radiolucency still is there. Now, like I had already mentioned, there will be history of trauma and caries will be there. And if you check these teeth, the teeth will be always non-vital. Okay, so that's a major feature. The teeth will be always non-vital. You do thermal testing or electric pulp testing or any kind of testing, the teeth will not respond. Okay, it will be completely non-vital. And large cyst, it can cause swelling and sensitivity and mobility and all will be seen. Okay, so This is the radiographic picture of the radicular cyst. As you can see, a well-defined radiolucency encircling the apex of the tooth, loss of lamina dura, and root resorption can also be seen. Okay, so this is a IOPA of the lateral radicular cyst. Okay, lateral radicular cyst can be easily confused with lateral periodontal cyst also. Again, a well-defined radiolucent area in the lateral surface of the teeth. And this is an example of the residual cyst. The tooth have been already extracted, but still the cyst radiolucent area remains. Okay, so such areas are called as the residual cyst. Now coming to histopathology, radicular cyst also shows its own characteristic histopathology. The lumen, again, we are discussing it in three parts: lumen, epithelial lining, and the connective tissue wall. Lumen will have lots of fluid and cellular debris like this. And the connective tissue lining, it will be usually made of non-keratinized stratified squamous epithelium. And it shows a peculiar pattern that is called as the arcading pattern. Okay, so this is the arcading pattern of the radicular cyst. Arcading pattern means the epithelium will be continuously proliferating to the connective tissue, and the connective tissue islands will get entrapped in between this epithelium. Okay, so that will create an arcading pattern like this. Okay, and connective tissue, since it is an inflammatory cyst, there will be lots of inflammation seen, and sometimes the cholesterol clefts like this. Okay, empty needle-like spaces like this will also be seen in the radicular cyst. Okay, so this is about the histopathology of radicular cyst. The non-keratinized epithelium in arcading pattern, dense inflammatory infiltration. Okay, and there are some characteristic features that you see in some of the radicular cysts, like Rushton bodies. Okay, so what are Rushton bodies? Rushton bodies are these pink-colored or eosinophilic, straight, curved, or hairpin-like structures that you see in the epithelium of the cyst. Okay, these Rushton bodies are seen only in the epithelium of the odontogenic cyst. Okay, there is something called as Russell bodies also. The Russell bodies are usually seen in the connective tissue. Okay, Rushton bodies are usually seen in the epithelium alone. Okay, so what are these Rushton bodies? There was like confusion regarding what are these Rushton bodies are. There are like many school of thoughts. Some say they are the degenerated epithelial cells. Some say they are like keratin-like substance, and some say they are the hemoglobin breakdown products. Okay, it's not yet confirmed, but you can think of it as a degenerated epithelial cell, or it might be a keratin-like substance, or it might be a hemoglobin breakdown product also. Okay, so these pink colored structures that you see, yes, that are all Rushton bodies. Okay, most commonly seen in radicular cyst, sometimes in dentigerous cyst and occasia also, but very rarely in dentigerous and occasia. Very common in radicular cyst. Okay, then another feature that you see in this radicular cyst is this cholesterol clefts. Okay, so what are these cholesterol clefts? They are needle-shaped spaces like this seen in the connective tissue of inflammatory cells. Okay, can be seen in dentigerous cyst also if it's infected, but mostly seen in radicular cyst and in dentigerous cyst also. Okay, so such needle-shaped spaces that you see in the connective tissue, they are called as the cholesterol cleft. Okay, so what are these cholesterol cleft? What happens is that through the blood vessels in the connective tissue, RBCs, they come out of the blood vessels into the connective tissue. Okay, so for clearing these RBCs, not just one or two RBCs, lots of RBCs will be coming. So for clearing these RBCs, what the body does is that they will send the macrophages. Okay, so the macrophages will try to clear off these RBCs, but the RBC membrane, okay, RBC membrane cannot be degraded properly, and lots of cholesterol crystals can be there in the connective tissue after the degradation. Okay, lots of cholesterol crystals from the RBC membranes that will remain in the connective tissue itself. Okay, so these cholesterol crystals, while after doing the biopsy and after doing the tissue processing and all, what happens is that these cholesterol crystals, they get washed away. Okay, the cholesterol crystals get washed away and only empty spaces like this will be seen in the connective tissue. Okay, so these empty spaces, we call it as cholesterol clefts. Okay, actually in the body, there were cholesterol crystals present in these spaces, but during the tissue processing, that cholesterol gets washed away. So only these cleft-like spaces will be seen in the radicular cyst. Okay, and you should also mention about the giant cells. Okay, giant cells and lots of inflammation will also be seen around these cholesterol clefts. Okay. Yes. Next is the calcifying odontogenic cyst, which is also called as the Gorlin cyst. Okay, do not get confused between the Gorlin syndrome and Gorlin cyst. Gorlin cyst is calcifying odontogenic cyst, and Gorlin syndrome is nevoid basal cell carcinoma syndrome, which we had already discussed. Okay, so the origin of this calcifying odontogenic cyst is mainly from the cell rust of serrae, the dental lamina remnants, usually seen in with equal frequency in both maxilla and mandible, and sometimes it will be associated with an unerupted tooth or an odonto, mostly seen in second to fourth decades of life. And this is an example of a central lesion. Okay, the central lesion means inside the bone. Peripheral lesion means in the gingiva. Okay, so this is an example of a peripheral lesion, and this is an example of a central lesion. So as you can see, it can produce a swelling as large as like 12 centimeter or like somewhere ranging from 2 to 12 centimeter. It can produce a swelling like this. Okay, so it can produce a marked extraoral swelling also like this in the patients. Okay, peripheral lesions will be very small like this in the gingiva. But usually if you see at the peripheral lesions, most of these peripheral lesions of this Gorlin cyst will be seen in older patients, like the ones in the 6th to 8th decades of life. Yes, you will be seeing the peripheral lesions usually in the older patients. Now coming to the radiographic features, it also shows a unilocular well-defined radiolucency, but it shows radio opaque structures like this. Okay, radio opaque structures like this will be seen inside the radiolucency. Okay, so radiolucent area with radio opaque structures like this will be seen. Root resorption, very common. Root divergence also very commonly seen. Okay, so the characteristic feature, if you look at the histopathology of this calcifying odontogenic cyst, is the presence of ghost cells. Okay, so these are the ghost cells that you see here. These pink colored, rounded, lamellated structures, yes, those are the ghost cells. Okay, ghost cells alone can be asked as a short note or a brief note. So please be prepared for that. And underneath these ghost cells, you'll be getting, you'll be able to see a stellate reticulum like the spinal cells, and the basal cells will be usually amyloblast-like. Okay, amyloblast-like basal cells means it will have a shape of a tall columnar cell. The nuclei will be very hyperchromatic, very darkly stained, and it will be seen away from the basement membrane. Okay, so that is the characteristic feature of this basal cells seen in COC. Connective tissue, less inflammation. Okay, since it's a developmental odontogenic cyst, usually less inflammation is seen. Okay, and another characteristic feature that you see is that in some of these ghost cells, these long-standing ghost cells, they can get calcified. Okay, so that can get calcified and can produce calcifications near these ghost cells. Okay, so that calcifications will be like blue in color. Okay, ghost cells will be pink in color. Calcifications will be usually blue in color. Now, another feature that you see in COC is this dentinoid material. Okay, dentinoid material means dentine-like material may also be seen adjacent to these ghost cells. Okay, so calcifying odontogenic cells, histopathology, don't miss out ghost cells, stellate reticulum-like spinal cells, the amyloblast-like basal cells, the dentinoid-like material, and calcifications is seen in the ghost cells. Okay, 5 points, do not miss out. Okay, so this is the picture that you can draw for your exam. There will be cystic lumen, calcification, blue colored calcification, and the ghost cells will be there. ameloblast-like material and the dentinoid material and connective tissue, less inflammation will be usually seen. So let's see what these ghost cells are. Okay, so these ghost cells, they're also called as shadow cells or translucent cells. Okay, why they are called as shadow cells? Because it seems like the ghost cells, they resemble like an epithelial cell only. Okay, an epithelial cell only, but it will be very large epithelial cell. Okay, very large epithelial cell, and it will not have nucleus. No nucleus inside it, but the outer periphery of the cell is maintained as such. Okay, so that's why it is called as a shadow cell. Okay, nucleus will not be there, organelles will not be there, nothing will be there, but a pink colored big cell with a clear outline will be seen. Okay, so that's why it's also called as a shadow cell or translucent cell. Okay, it can undergo calcification and can produce calcification in the cystic epithelium, most commonly seen in calcifying odontogenic cyst and the complications of calcifying odontogenic cyst, that is the dendrinogenic ghost cell tumor or the ghost cell odontogenic carcinoma, or sometimes rarely in odontome also, you'll be able to see ghost cells like this in the epithelium. Okay, so what are these ghost cells? Again, like the uh, Russian bodies or Russian bodies we had discussed, there are like three school of thoughts regarding the ghost cells also. Some say it is because of aberrant keratinization. That is like lots of what to say, not organized. Okay, without organization, so much keratinization is happening. So that resulted in the formation of ghost cells. Then there is a theory on coagulative necrosis. That is, the cells there had undergone necrosis. So only their outline is there. The nucleus and all is lost. Okay, that's one. Another theory. And the third one is it is formed because of the accumulation of enamel proteins. Okay, lots of enamel protein is getting accumulated there. That's why it is forming this ghost cells. Okay, so these are the three theories regarding ghost cells. One is aberrant keratinization, lots of keratin. Then coagulative necrosis, and last one is accumulation of enamel proteins. Okay, so because of this only, this uh, ghost cells are getting formed. Most commonly seen in COC. Okay. Then the next one is the glandular odontogenic cyst. Okay, glandular odontogenic cyst is not commonly asked in for the university examination, but here I am mentioning because it is an important and aggressive cyst. Okay, an aggressive odontogenic cyst. That's why I am mentioning it. It is also called a odontogenic cyst, and as you can see, it is most commonly seen in the 40, like in the late 40s, and most commonly seen in the mandibular anterior region, and the large lesions are there. Okay, large lesions can produce pain and paresthesia. Okay, so this is the radiographic feature of glandular odontogenic cyst. So it will produce a unilocular or multilocular radiolucency like this with well-defined corticated rims and the characteristic histopathological feature. Okay, so the histopathology, if you look at this glandular odontogenic cyst, it will have the lumen, the lining, and the connective tissue. Okay, so the lining will be usually non-keratinized stratified squamous epithelium, and the superficial cells, it will show something like a hobnail appearance. Okay, so what are these hobnails? So these nails that you see, yes, those are the hobnails. Okay, so in the early 70s and 80s, mainly in European countries, what they did was to increase the lifespan of their shoes. What they did was they used to like insert such hobnails on the soles of the shoes. Okay, so they used to insert such hobnails on the soles of the shoes to increase the lifespan of their shoes. Okay, so such nails are called as the hobnails, and these cells that are seen in the superficial epithelium will show something like a hobnail appearance like this. Hobnail appearance means the top portion will be a little bit wide, and the apical portion will be usually pointed like this. Okay, so this is a typical appearance of the hobnail appearance also. Okay, and in between the hobnails, you'll be also be able to see goblet cells, and then glandular duct-like spaces like the these will be seen in the epithelium, and it will have like a pinkish liquid inside it. Okay, so this pinkish liquid will be usually positive for mucicarmine. Okay, so such pinkish liquid and mucicarmine positive fluid is usually seen in salivary gland tumors. But since it is a glandular or endogenic cyst, it can be seen here also. Okay, so that's why it's also called as stylo-odontogenic cyst. Okay, and the epithelial connective tissue interface is usually flat. No retiridges are usually seen. And since it's a developmental odontogenic cyst, no inflammation is also usually seen. Okay, so there are like some major and minor criteria for diagnosing this glandular odontogenic cyst. It was given by Kaplan in the year 2008, and it is called as Kaplan's criteria. Whatever we had mentioned now, like the non-keratinized epithelium, the hope-nail cells, and the intraepithelial mucus pooling microcyst, and the lining epithelium, and the clear or vacuolated cells that are only there in this Kaplan's criteria also. If they ask a short note or something, a question based upon Kaplan's criteria, please know that it is for the glandular odontogenic cyst. Okay, so these are the major and minor criteria that is related to the glandular odontogenic cyst given by Kaplan in the year 2008. Okay. Okay. So I think that's all for today. There are like lots of odontogenic cysts. Mainly, we had discussed about almost all the questions that had come in the previous year university examination papers. Mainly, you should focus on dentigerous cyst and OKC. And whenever you are writing the histological features and the radiological features, please make sure that you draw diagrams related to it. Okay, please draw diagrams related to it and make sure those diagrams are neatly and properly labeled. Okay, that's very important. The diagrams should be neatly and properly labeled also. Okay, so if you have any questions, you can ask now. Or if you want to go through the topic once again, and if you are having any doubts, you can directly comment below this video. We will definitely answer it. Okay. Any doubts? Yes, doctors, if you have any doubt, you can put it in the chat box. Okay. Or if you don't remember the doubts, then you can definitely put it under the comment as a comment under this video. We will definitely answer it. So all the best for your preparations. Do well, keep studying and keep revising. Okay, so all the best for your preparations. Do well. Bye and good night.